Well, thank you for a very nice introduction, and it's actually my honor and privilege to be here. When I received the email from Dr. Iceland, I couldn't believe it. It was actually one of the nicest things that's ever happened to me. So I was really very happy here at Harbor-UCLA, working especially with Dr. Iceland and the staff. In 2005 or 6, getting ready to graduate from UCLA GI. I was going to go into private practice, and it was a phone call from Dr. Iceland that changed everything for me and my path in my career. Basically said, we want to start a fourth-year fellowship. We really like you to be our first fellow. I wasn't sure. I said, let me think about it. I'm not sure. I think right there, I'd tell you the answer was probably going to be no, because I was getting ready to go to work. But the one thing he told me was, he said, you're like family. We really like you. When I heard that I thought about it for like 30 seconds, and I called him right back and said, I'll be your first fellow. So when I got involved, changed my schedule around, did whatever I can to make it out here today. So it's a privilege for me to be here. I'm very happy, and I want to talk to you about something that I'm extremely interested in, and I think it's going to change the way we think, the way we perform liver biopsies in the future. So the question is the paradigm changing? We'll find out. The reason I have this actually says GE Lab. I thought that was kind of cool. It says GE LA. So you can see here's a sample of using a technique for EUS guided liver biopsy. And it's not just like I picked the best sample. I think I have so many I don't know what to do with them, but they're all over the presentation. But I'll go over everything in general and actually review, basically what other doctors have done, other physicians and institutions have done, and where we're at right now with that. So that being said, it's hard to leave to travel when you have a 5-month-old baby. He is right there. He was born right at DDW, so I was DDW this year for a great reason. And the key thing is, it's really difficult to leave home when they get, 5 months later. They grow up so fast, and that's completely true. And there's my other little 4-year-old. So, like I said, that's why I don't travel very much. But for this, this occasion, it was, like I said, it was an honor to be here. These are my disclosures, and the reason I show this is because, as advanced endoscopists, we really need to give credit to the people that work with. This is my endo staff right here. They really don't look like that; they're a little prettier. And this is me taking care of the patient, but they're part of your team. They're your support, and it's really important. I'm not sure if there are any nurses or techs here, and please always acknowledge them, because they really can make your break. If you have a very good staff, they would do anything for you and really take great care of your patients. So they're 50-50 when I do any advanced or difficult procedure. So that being said, we'll briefly go over the introduction, EUS guided liver biopsy for parenchymal disease. What are the published studies, and what's the technique? I started calling it a Nieto technique because that's pretty much what Janet Shaw kept on calling it, so I eventually kind of started doing it. And as a joke, one of my friends hashtagged it, and I kept the hashtag, which I thought was pretty fun. I don't know if you guys know, Austin Chang is a big GI social media. And then we'll go over some case studies and how to use a similar technique for other lesions, not just benign disease. And we'll conclude everything. So, FME parenchymal disease has emerged to be very safe and effective. There to other alternatives, like transjugular as well as percutaneous. And it's been used to evaluate both benign and malignant disease, but we're going to concentrate today on benign disease. And that's just another sample of what it looks like. One of the issues everyone asks me is, how do you convince your colleagues, your pathologists, to accept this? Right? The reason I put this here is, put a karate chop to poor liver biopsies is because I'm going to show what has been accepted in the past by pathologists from percutaneous liver biopsies, and it's nothing as good as what we can do with EUS guided liver biopsies. Again, here's a nice core, about almost 6 centimeters. Just one pass, completely intact. Same thing right over here. So, when is the proper indication where you want to have the patient undergo EUS guided liver biopsy? Well, obviously you have a significant amount of patients who refer for annual liver function tests. So as you consider liver biopsy, patients with viral hepatitis most time do not consider liver biopsies. But you have a subset of patients that require biopsy for abnormal liver function tests. You're not sure if it's pancreabiliary disease. You're going to send them from an MRCP. But you're able to do the same thing with an EUS scope, evaluate their pancreabiliary system, and also at the same time take that liver biopsy. As you know, Hep C is going to be cured pretty soon. The key thing is NASH. That's our biggest issue right now. And I'll present some data regarding NASH, why it's so important to biopsy those patients, and what other institutions have also done. So these are what I kind of follow. If they're undergoing an EGD or an EUS for another reason, it's a perfect time to do an EUS liver biopsy. It's an extra day. They don't have to go to IR and spend 4 or 5 hours there in IR just hanging around. It's an extra day of work that those patients are missing. And this is the key thing right here. We can biopsy both lobes. While transjugulars are kind of limited, as well as percutaneous. And these tend to be obviously smaller, biopsy samples. Now, if you're looking at portal pressures, that's usually a patient with cirrhosis. You're not going to do a liver biopsy in those patients. Those are the ones that, should go to transjugular liver biopsies. But eventually, with EUS, those borderline patients, you're not sure they're cirrhotic, you can actually, at the same time, in the future, be able to measure portal pressures. So why EUS guided liver biopsy? Is it safe? Well, there's not data showing that it's extremely safe, because as you're passing that needle through, you're seeing live, tissue acquisition, and you're missing the vessels you're seeing. If you hit a vessel, you can actually see it and take care of it right away if you notice anything. But the key thing is it's direct visualization and basically live Doppler and ultrasound. Not like they do percutaneously. They Doppler to mark the area, have you breathe in, and you take the sample. Sometimes they get other organs. We tend not to do that because everything is live and we know exactly where that needle is going. So is it clinically effective? We'll go over the research studies and what other people have done. And does it improve patient experience? So we're living in a world of patient satisfaction scores. This is huge. I can tell you a story of a nurse in our unit that actually came to me and said, I'm going to try this new medication, Upavia, for my PBC. But they want me to do a liver biopsy, because last time I had a liver biopsy was over 5 years ago. So I reviewed her liver biopsy from 5 years ago. She had a positive AMA, and she had 2 portal triads. There's 2 portal triads that were checked. And they said, well, it's probably early PBC, let's start treating you with ursodiol, and that's her diagnosis. 5 years later, she thinks her prognosis of 5 years is terrible. Well, we ended up doing her EUS guided liver biopsy. We got 33 portal triads, and she does not have PBC. It was a false positive AMA. So, and the key thing she told me was, well, I'm going to have to take up the whole week from work. I couldn't believe the next day she was on the floor working again. So that is, the recovery time is like an endoscopy of 30 minutes. And then the cost benefits is you have to look at it, obviously it's more expensive to sedate a patient, but you're basically doing an EUS like an MRCP and also liver biopsy like another. So you're basically putting 2 studies or an EGD. So you're really properly evaluating the patient and doing 2 procedures in just one day. And it's a much quicker and faster recovery day. So these are the patient selections I've started looking at. If the patient needs sedation, usually the ones that need sedation tend to be the pediatric patients. So I do a good amount of pediatric liver biopsies. And if they need both flows, especially if they have fatty liver. And obviously any non-diagnostic conventional liver biopsy, they still get the diagnosis. Any other reasons you're looking for this? Obviously, now you start seeing varices and confirmed portal hypertension. Most of the time we don't need that. There are some instances where we do a biopsy and we found nodular regenerative hyperplasia and other conditions such as infiltrated lymphomas that can potentially cause portal hypertension. So this is just their standard. I mean, if somebody has an IR over 1.5 or 50, we all know we're not going to put a needle on their liver. And that's actually another almost 9 centimeter sample. So what's the criteria? So ASLD criteria is 2 centimeter total tissue and 11 portal triads. From the Asia Pacific Society of Liver Disease is 1.5 and 10. So if you actually start talking, when I started getting into liver biopsies, everyone's, for some reason it was 7. 7 was like the magical number. 7 portal triads is all you need. So you start looking at these large percutaneous studies, what's the average CBT? 7.5. But that's not what the requirement is for ASLD, ESAL, and Asian Pacific Study of Liver Disease. Then transjugular, again, 6.8. And even the total length is only 1.77. This is a total amount of tissue they're getting. So they're not getting sufficient tissue. But the theory was that 7 was always okay, and it's not. So if you actually look at this study done by, published in Clinical Pathology, only 19%, 20% had adequate biopsies. And that's defined as over 11 portal triads and at least 2 centimeters of liver tissue. I mean, this is way over 2 centimeters, and there's probably 31 portal triads here. And the patient went home the same day within 30 minutes after the procedure. So this is a study done by Dr. Nieto, a good friend of mine, looking at, well, should we just biopsy both lobes or one lobe? And what he did find is, when you start biopsying both lobes, you're averaging about 17 portal triads versus 13, compared to percutaneous transjugular. Now this is using a different technique and a different needle, and this was published in 2014. Same thing here, looking at diagnostic samples, both lobes obviously superior. So the question is, do you need to use both lobes? Well, I'll answer that as the needles have changed. Those were F and A needles. Now we're using F and B needles, which is changing everything. They're basically game changers, even just for other conditions, other liver biopsies. So this is a really interesting, really nice study looking at percutaneous versus transjugular approach for liver biopsies. 75 patients in the IR group, average of 13 CPTs, 36 total, and the EUS group was 46 versus 11. So it met criteria, but again, they were using a regular EUS needle, and they were not, they were getting a lot of fragmentation because they were doing this back and forth, typical FNA motion that we were taught to do. And I'll show you I use a completely different technique. This is actually one of my favorite studies done by a friend of mine, Dr. El Shafi, and he uses my technique, so I know you'll see his numbers significantly better. Average of 20 portal triads versus 9 versus comparable 20 with the transjugular. But the key thing is here, the recovery time is significantly faster. This is actually earlier on we were keeping a closer eye on these patients. And the intact length, this is how much intact core that you can evaluate it. It's about 17 to 1.7 centimeters. So the key thing here is shorter recovery time and intact, and great samples over 20. So how do you do this procedure? So how do you access the right lobe and the left lobe? So basically, undergoing EUS, left lobe, you're basically going through the body of the stomach. You see the left lobe, you measure it out, and you do your biopsy. The right lobe, you go to the duodenal bulb, you go all the way to the left, all the way to the right. You identify it. How long? It's usually 8 centimeters. You can do a full 8 centimeter thrust, or basically the whole liver core biopsy. I do use a 19 gauge needle for all my liver biopsies as well. Obviously, you have Doppler, and you have to do all the basic things. So this is a really nice study done a long time ago by Dr. Schiff and his group at the University of Miami. What they did is during laparoscopic cholecystectomy, they started out of 124 patients. They biopsied the right and left lobe of any patient that had abnormal liver function. So we're probably talking about fatty liver for these patients. What they found is 1/3 of those patients, the right lobe and the left lobe had a different fibrosis score. So it means if you do a biopsy of the right side and it's an F3 or an F2, but the other side is an F4, so it means they have cirrhosis, you just underdiagnose that patient, and you're going to miss the potential of screening them for cancer or even transplant. So this is extremely important. 1/3 of the patient, that's a big number. And if you look at my 600 cases, it's about 25% and 22%, 22% and 25% inflammation difference. So the reason I show this is because hepatitis C is pretty much gone, and these are liver biopsies you're going to be seeing. So imagine if you need to do a percutaneous liver biopsy in this gentleman. It will be very difficult, very challenging. At least I wouldn't try it. But it would be very, and these are the patients we're dealing with in the future. So I think it's extremely important that we really start thinking about other approaches. So this is a study also done by Dr. Beal. And what he looked at 38 patients with fatty liver, NASH. And what he found is if they were just, they did right and left lobe. If they were just to take the right lobe information, 21% of those patients were understaged. 21%. It's basically 1 out of 5. I mean, that's not right. That's a big percentage. And inflammation, which is not that big of a deal, was understaged in 13%. as well as steatosis. But the key thing is fibrosis. This is probably what we care about the most, to be accurate. We want to get a global picture of the liver. Currently, these are all the studies that have been done, not all of them, but the majority up to 2017, including mine, of 165 cases. I do have another study that over 420 cases. Average CBT is 18. This is early on, I had a different technique. The majority of the other ones were 14 or 2, but they were using FNA needles. And this is basically, Dr. Adler put this together, 436 patients. And diagnosis rate of 3.9%. And 2% adverse event, but they were calling adverse events even if you have right upper quadrant pain after, which a percentage of the patients do have. Out of the 437 patients, I think almost 200 are my cases. So this is a little, I think it's a little biased because it was mainly half over my cases. I think we have to get, this has to be redone with all the new studies that are out currently. This is another study also published also by Dr. Deal's group, looking at 40 patients again. For now, we're going to use FMB. It's really, it's clear cut that FMB is the way to go. 43 forward triads average, total length 2 centimeters. 37.5% post-procedure pain. That's expected. 99.9% of the patients go home without any pain. We rarely keep the patient home. Another study, also done by Dr. Deal, looked at the different, okay, so the next question is, well, we already established it's an FMB needle we're using. Do we have to use wet heparin, dry heparin, no heparin? The question is, all that doesn't make a difference whether you use heparin or this dry. The key thing is, the wet technique is what they're using is probably the most accurate. And if you add heparin to it, it won't make that big of a difference. At least not statistically. So I don't use heparin. I don't flush with heparin, I just use saline. So then, the other question everyone's asking, well, I use a 22 gauge needle as opposed to 19. I'm kind of afraid of using 19. Well, they did a really nice study here. This is actually one of my colleagues when I was in Orlando, Dr. Hassan, and he did 40 patients, but he took 3 biopsies, 2 from the left and 1 from the right. And what he found was that they got plenty of CPTs and plenty of tissue, and it was a very safe, prospective study. Postoperative pain, about 15% required. Now he's measuring the postoperative pain as a 15 that required pain medication. You can have up to 33% of pain, or actually not as high as 50, where they may not require pain medication. I said, no, I just feel like a little dullness there. But it's not true. They're not really getting any medication for it. And then another great study, this is I think the last study we have, is from the Mayo Clinic in Rochester. And Pate's a good friend of mine. He actually, I worked with him on a few projects, as well as Barney. And they looked at, again, 40 patients. Like 40 patients must be like around that key number. And what they looked at is MRE correlation. So there's a big push now to do MR elastography. And what they found, only 68% of the time did they actually have a correlation of fibrosis and inflammatory score. So is MRE the best way to go? The answer is, yeah, in certain patients that don't undergo a liver biopsy. But, there is a miscorrelation that's significant. I mean, that's almost 40%. So it's definitely 30%. So really think about MRE. And also, again, this is at the Mayo Clinic where you expect their reader variability to be very high and actually great quality in our eyes. So this is actually my study looking at 210 patients using the Franston tip needle, the 4-tip. Also, one is the acquire, one is the charcoal. And the technique I use, which I'll illustrate next, is a one-pass, one actuation technique. Just one thrust. Then I add it's a 19 gauge needle, then I add my suction. I hold the suction there for a few seconds, pull back about 1/2 millimeter, 1 or 2 millimeters, and change the angle, push back just to cut the sample. Because all the suction is really doing is holding that sample that I actually, give a good thrust or a good strike into the liver, and it burrowed through, and it got captured in the liver. I'm sorry, in the acquire or the charcoal needle. And, basically then I pull it out. Once I keep everything straight, so I don't use a stylet. Once I pull out the needle, it goes straight to my tech, and then I flush it through. I don't use a stylet, I just flush it right through, directly into the cells. And basically now, based on this study, I only do one pass, unless it's a fatty liver. I use two passes. And it's more to look at the right and the left lobe. So then it just also goes over the preparation of the specimen. We can skip that, and so I can show the video. So as you'll see here in the video, it's on the left lobe, and right lobe, and it's just a quick thrust, and then that's what you get. I mean, this is what you see, and it's not just one. This is pretty much all my samples. Once in a while, when you have a cirrhotic patient, you may get some fragmentation, but these are the samples that we're getting. Actually, this is a pediatric patient. So it's a quick thrust. That's the key thing. This is also looking at both, the 210 versus 210, looking at the total. The intact was about average of 3 versus 2.7, 6.5 versus 6, so way above the 2 that's necessary, 2.5 that they require, and 24 CPTs, which is basically double the 11. And this is average. This is the whole 210 patients. And actually 100% of the patients had 11 or more CPTs. And then I started looking, well, I wonder if it makes a difference based on their fibrosis score, if one needle performs better than the other. And we actually found is when there's more fibrosis, you actually start getting more CPTs using the Francine tip needle. And that was, obviously some of these are not statistically significant, but there's a trend. And this is basically the summary of that study. We found 100% of both needles had adequate tissue, and 100% had adequate CPT. The fork tip was about 98%. There was 1 or 2 patients that had about 9 or 10, so it didn't meet the 11 criteria. But 4 patients had pain after. They all required pain medication after, and 4 were hospitalized post. Those were 3 were small small bleeds that were contained. No need for anything else other than observation, and 1 with a vomiting. And what I attribute that to is when I was doing those passes in the left lobe, I was actually causing hematoma on the other side of the lobe. So now I actually, on the left lobe, instead of doing 8 centimeters, I'm doing more like 6 to 7. So since then, I haven't had any significant hematomas or any other issues. And this is basically showing more case studies of samples, what the pathology looks like. And the pathologists love this. I mean, this pretty much everyone that I've trained to use this technique, and this is what they're seeing as well. Including, I just trained a pediatric physician who's doing liver biopsies now. He just got liver biopsies in Cincinnati. So then I started using the same exact technique for FMB for other samples, such as, in this case, pancreatic mass. So this is using a 19, nice little pores, but again, using this strike technique. I call it 3 strikes, you're out. So basically 3 strikes in a fanning type of method, but it's only 3 actuations with hard strikes. Obviously, with a pancreatic mass, if it's a 3 centimeter mass, you're only going to go about 3 centimeters deep. 4 centimeters, about 4. And I use anywhere between I use a 22 and a 19, depending on where you're located. As you can see here, this is the samples. This is a core sample of a pancreatic mass FMB core tissue. Another patient also with a pancreatic mass and also liver metastasis, using the same exact technique. I use a 22 here and a 19 here. A patient with autoimmune pancreatitis, I usually tend to use a 22, and again, pretty nice samples without any issues. For this one, I used a 19 and a 22. I had 3 cases. This is actually a splenic mass biopsy with lymphoma. So this avoided the patient undergoing a splenic. And this is a patient that I ended up doing a EUS guided kidney biopsy for parenchymal disease. And basically, these are the criteria. I don't have much of a referral for this, and I just did 1 case to kind of see what it looked like. This is the samples we get. And if you've ever seen if you're on YouTube, a kidney biopsy, it is scary. They're on their back, they have this big needle, they're pushing it, it kind of ultrasound a little bit. It's pretty, aggressive looking. So this is much easier. I mean, anyone who does the EUS can tell you that it was right there. I'm sorry, the kidneys are right there. They're easy to get access. And that's basically it. These are my little guys before these little guys right here. And when you have long hair, make sure you have a cut it for swimming. You don't learn how to swim in Florida, he's got a pool. So, conclusion, this is an emerging alternative, and I think it's changing the paradigm for what we're going to be doing in the future. And it's eventually, I think, going to become a gold standard. It's extremely efficacious, as you can see here. You can have the ability to use both sampleable flows, which we have evidence now that is actually extremely important. And using my technique over 840 samples, there's now another 150 that I can't put here because I'm not mixing any samples, any populations together. Again, have met criteria, just letting help the majority of the patients. Postoperative pain, about 37%. 100% patients get relief, and less than 1% complications. So any questions? And again, thank you again for giving me this opportunity to talk about something I'm extremely passionate about, but most importantly, one of the greatest places to train and the greatest faculties, great friends, like I said, family. Thank you.
Thank you for a great talk. So when they have pain, do you image them for bleeding automatically, or what do you do?
No, I don't. Actually, up to 50% will have pain. What I basically do is I ask them, what's your pain? You have to be careful from these patients. They have different tolerance of pain. I start with 2 milligrams of morphine post-operatively, or 25 or 50 of fentanyl, depending on their size. And I would tell you about 100% of the patients with pain goes away.
Within a few hours?
Within 30 minutes.
Oh,
Pretty quick. And then they're discharged. Those patients are discharged over after 30 minutes.
so you observe for like an hour?
Well, yeah, you have to observe if you're given a narcotic, yeah. So we observe post-narcotic. So anywhere between 2 to 4 milligrams of morphine. We used to get 1 of Dilaudid or 0.5 Dilaudid, and 25 or 50 of fentanyl. I haven't had to hospitalize anything yet. Now, post-op we've had 4 hospitalizations, but they all did fine. It's an expected complication. And I think I can attribute it to what happened in those cases. Thank you for the question.
Yeah, thank you for a great talk. You mentioned you preferred the 19 gauge needle, but you have a study that showed that 22 was also...
Yeah. But it's only 40 patients versus 840 biopsies, and they only do 40 patients. And they basically took 3 biopsies. Eventually they're going to have a complication about it. So this is just one pass. Now they're doing a different technique. They're doing this back and forth, 2 or 3 ins and out, a slow pull, and they're getting a bunch of little fragmented spaghetti pieces. Their intact is they didn't even publish their intact because it's my average intact now is almost 3 centimeters. Well, their average intact is probably less than a centimeter.
So can you go over the technique again of how you do it? Actually, how does the needle,
right.
Do you have the stylet in, you don't have the stylet in?
Right, so but basically if you guys have any type of needle, like you guys can grab me a needle from back there, I can show you, I can demonstrate it, but the key thing is you need to have your staff. That's why I mentioned my staff. It's extremely important. They're all trained. They take everything out, take the stylet out, they flush it, whether you're using a 22 or a 19. You flush it.
And you see.
Just you can use safe, yeah, sterile safe. Then I go to the right lobe is usually where I start at. I go all the way to the left. I see my trajectory, which is usually 8 centimeters. Make sure there's no big blood vessels, and I do a quick strike. Also, if someone get, I don't care which needle you
yeah, someone with yellow.
Okay. Because I can demonstrate a technique. The core needles are getting rubber samples, and that's been shown with Dr. Deal's research. And it's a quick pop. Then I get my syringe and put it on after, because you want to have that open needle to bore through and capture. Now, if you go real soft, you're not going to capture much. You got to go quick. It's a quick snap, and that's what captures your tissue. And then all you're using the suction for is just to anchor that piece there. And if you ever see a little bit of saline going up, that means the tissue's already moving up a little bit. This is displacing some of the saline. And that's where you can actually turn off your suction because in seconds. And just slowly pull it out. Keep the needle straight. You give it to your tech, it's usually to my right side, and I flush it through.
The syringe is empty, right? It just has negative pressure or suction, but it's empty. It doesn't have saline.
Yeah.
That's not.
Yeah, this is it's a needle, but it's all right. I'm just gonna. So you take out your stylet. Take out the stylet. You have your tech or your nurse flush it. Then usually it's 8. It's either if it's in the left lobe, it's anywhere between 6 and 7. Sometimes 8. The right lobe is usually 8. And it's a quick, you have to hear that. It's not, with my syringe on, it's suctioning. If basically I lift, if I see if it gets displaced right away, I turn off my suction and just slowly pull back out. And then I flush, keep everything straight, and flush it directly into the formula, like you would put in a regular biopsy, like stomach biopsy.
You mentioned you advance it a little bit after you start suctioning.
Right, so once you do this, and you put on your suction, if you're not getting anything at all, what I like to do is, I like to just push it up about this much, maybe a millimeter, and then just tip up just to move the angle, so I can then, push it through and, cut the end of the tissue in case it's, so the tissue doesn't pull it off. But you're just cutting the tissue at the end. And then slowly pull back with suction for like 2 or 3 centimeters and lock it. And then slowly come out and again flush it out. And so it's very similar to like a percutaneous, when you just really hard thrust, slowly pull back, and then you're out and flush. The thing is that you're not going 8 centimeters, you're going much smaller. So you're getting much, you're getting this, this much tissue. It's all the way down. Now you can get some stomach tissue, who cares? I mean, you just gave your pathologist 7 centimeters of tissue with over 30 plus pore riots. They're going to be fine with it.
And you get it one time on the right, one time on the left.
For fatty liver, right and left. For anything else that's not fatty liver, you can see fatty liver in the EUS. Just one pass. Based on my technique, every patient has the average 20-something pore riots. So it's never under 70 level. So again, you're only doing 1 pass, not 3 passes like they did with the 22. And not multiple max and 4. So,
Jose, why not do suction on the way in also? Have you tried that? Is there any problem with that?
Yeah, it just blocks basically pouring through. So I'm using this more to pour through. When I use suction, it prevents tissue from getting up because there's no pressure on it. So if it's wide open, everything's just going through.
Also, we've been, I noticed the 19-gauge pancreatic mass pictures you showed there. We've been using a lot of 22-gauge for pancreatic mass as core needles and getting good results. And a big part of the reason is that I think we're doing less passes and we're getting a lot of tissue. Have you seen any other benefits in terms of doing core in the pancreas as opposed to just FNA?
Yeah, all the new genetic studies that they want, all the oncologists want for different medications. They're out there, yeah. They're huge. They love these. They don't want me doing FNA anymore. When you give them that kind of tissue, they can do anything. They can do genetics on that. They can do specific medication. I mean, the future is you're actually going to have these personalized medicine for every single patient. Their tumors are different. So this is the future. This is why F&B is pretty much here to stay across the board.
So for your facility, so you're doing the PEDS cases, how are you getting the privileging side of things?
I'm the only advanced endoscopy who does PEDS, and I think only 2 of us in Florida. So I get referrals everywhere. And I've done enough cases where I've done, just like for example, in just EUS axial drainage for pseudocysts, I've done over 30 cases. Probably the most in the world. Because we're a big referral center at EUS. So since I'm the only one doing it at a high frequency, the privileging is given based on the numbers.
It's a bit tricky. So for my facility, I'm just having that be admitted and scheduled on your part. PEDS GI, they're not doing it, so they're not.
Well, that's the way it's done. The PEDS GI can take care of patients. I just do, I'm like an IR, like a radiologist, interventional radiologist. I just do the biopsies and then go back to the service. Now I do some outpatients, obviously, as well. But it's the same thing. I mean, that's what I like about our colleagues in numerous pediatrics is they'll come in the room and watch you do slide labs with ERCP or whatever you're doing for them. This is training. They'll help you manage the patient, take care of the patient from there on with your assistance.
You mentioned you can recognize fatty liver pretty well with the EUS if you actually look at the numbers to see how accurate is your visual diagnosis compared to the histologic.
Yeah, it doesn't correlate. Even if as many as I've seen doesn't correlate. There's patients that their livers just light up with some inflammation. They do have fatty liver, but you can't tell the fibrosis. but you can tell there's fatty liver, which is all you really need to know. It tells you gotta do the right and the left. Any other questions or anything else you want to explain a little bit? Well, thanks guys, I appreciate it.